This week's module will provide a brief introduction to cost-effectiveness analysis. Cost-effectiveness analysis provides a framework for evaluating treatment options with the aim of improving the allocation of scarce healthcare resources. There is vast literature on cost-effectiveness analysis, both about the tool itself and applications that are employed. This lecture will provide a basic introduction to cost-effectiveness analysis, focusing on the incremental cost of effectiveness ratio, commonly used outcome measures, and some of the controversies surrounding the use of cost-effectiveness analysis. This week's module included several readings, including a short piece on determining value in the U.S. healthcare system. It also included an overview of cost-effectiveness analysis, a discussion of the advantages and concerns regarding the use of quality-adjusted life years as an outcome measure and cost-effectiveness analysis, and lastly, a piece on the ethics of cost-effectiveness analysis. So let's jump right in with the incremental cost-effectiveness ratio, which is commonly used in the literature. Let C sub 0 be the cost of the baseline treatment, and let E sub 0 be its effect, say on years of life saved or quality adjusted life years saved. Let C1 be the cost of a new treatment, and let E1 be its effect. Then the incremental cost effectiveness ratio of the new treatment relative to the baseline treatment can be presented as the following ratio, which is called the incremental cost effectiveness ratio. And so here we see the change in cost over the change in effect, and that will be this incremental cost effectiveness ratio. So with this, we have four possibilities. A new treatment may be more effective and cost less. It may be more effective but cost more. It may cost less but also be less effective. And fourth, it may cost more and be less effective. We can show all four of these possibilities on the incremental cost effectiveness plane. Here we have the range of costs to be considered, where we're considering the incremental cost of the new treatment relative to the baseline treatment. And we can also look at the incremental effectiveness of the new treatment relative to the baseline treatment. If we have all of these possibilities, we can see that a new treatment may be more effective and less costly than the baseline treatment. It could be more effective, but also more costly. It also could be less costly, but less effective. And it may cost more, but also be less effective. So cost-saving treatments should be implemented, and treatments that are more costly and have reduced benefits should not be implemented. But what about treatments that are more effective but also more costly, or treatments that are less expensive but also less effective? That's something we'll be considering using the incremental cost effectiveness ratio. So in the northwest quadrant, we should not implement this new treatment because it's dominated by the baseline treatment. And in the southeast quadrant, we should implement the new treatment because this is the dominant treatment. It's both more effective and less costly than the existing or baseline treatment. For those more costly treatments that are more effective, or for less effective treatments that are cost reducing, we can compare the treatment's incremental cost effectiveness ratio with a certain threshold. And this threshold may be socially determined, economically determined, say 3 times GDP per capita per quality adjusted life gained, or also based on a given budget, possibly for a public health department. So graphically, using this cost effectiveness plane, we can see the threshold for the incremental cost effectiveness ratio would be placed here. So suppose that a government decides that a new treatment is cost effective relative to the baseline treatment if its incremental cost effectiveness ratio is less than or equal to $100,000 per life year saved. This is going to be the relevant threshold when conducting cost effectiveness analysis. And we'll place that threshold here in this cost life year space. So if the new treatment is more costly but offers greater health benefits, it should be implemented if its incremental cost effectiveness ratio is below the threshold or in this area here. And if a new treatment is less costly but also less effective, it should be implemented if its incremental cost effectiveness ratio is above this threshold. And that's because the cost savings attributable to the intervention can be spent elsewhere in the budget to produce more health than is lost. And in this case, anything that's above that threshold for a treatment that is less costly but also less effective, that would be a cost-effective treatment to implement, because the budgetary resources that could be saved from that treatment could be redeployed elsewhere to increase quality adjusted life years. So treatment number one, as shown here, has an incremental cost effectiveness of $50,000 per life year gained, and that treatment is below the threshold. So we would say it's cost effective. Treatment number two has an incremental cost effectiveness of $200,000 per life year gained, which is above the threshold. And so based on that threshold, we would say it's not cost effective. Treatment number three has an incremental cost effectiveness ratio of $150,000 per life year, which is above the government's threshold. Again, the general idea is that selecting treatment number three would generate substantial cost savings for the government healthcare program, for instance, and those financial resources could then be shifted to other healthcare interventions that are more cost effective and which yield additional life years at lower cost, like treatment number one. Treatment number four has an incremental cost effectiveness ratio of $50,000 per life year, which is below the government's threshold. And in this case, the reduced effectiveness of the treatment does not justify the cost savings for that treatment. Something else we want to consider when we're talking about cost effectiveness analysis, and that is who was considering the incremental cost effectiveness of the treatment. This could be patients, it could be patients' families, it could be the private insurer, and it also could be the providers or public health insurers, or even the government, or it could be from an overall social perspective. Here's a patient's perspective example. Since there is an additional benefit of the telemedicine visit, here's a patient's perspective example. Since there is an additional benefit of the telemedicine visit, such as patient education, and there's also a lower out-of-pocket cost or copay for the telemedicine visit as a patient, we may find the telemedicine visit to be highly cost-effective. Put simply, the telemedicine visit costs less and is more effective, and in this case, we don't need to calculate the incremental cost-effectiveness ratio, as the telemedicine visit dominates the primary care provider visit in this example. This is not even considering the time and transport costs saved by the telemedicine visit. And if you included those costs by adding them to the cost of a primary care provider visit to get the full price of that visit, that might make the telemedicine visit even more appealing for the patient. In practice, most cost-effectiveness analysis studies focus on the incremental cost-effectiveness of interventions for entire populations rather than for individual patients. With that in mind, suppose that there's a new drug that offers an improved therapeutic benefit over the baseline treatment on average, but at a much higher cost. Specifically, suppose that the baseline treatment cost $100,000 while the new drug costs $500,000. And further, suppose that the baseline treatment extends life by 1 year on average, while the new drug extends life by 3 years on average. What would be the incremental costs per life year saved by this new drug? Here we would set up the incremental cost effectiveness ratio. We would see that the cost would rise from $100,000 to $500,000, and the effect on life you've saved would raise from 1 year to 3 years on average. So in this case, we would have $200,000 per life year saved for that particular drug. And so we would say that while this new drug is much more expensive than the baseline treatment, it extends life by an additional 2 years on average. Now, this raises the question, should the insurer cover the drug? Well, that ultimately depends on the threshold that's being used for the cost effectiveness analysis, as well as the insurer's budget or willingness to pay for that particular drug. And if we have a threshold like this for the incremental cost effectiveness ratio, which would be $200,000 per life saved, we would say that the intervention from that new drug, which is both more costly but also more effective, would be right on that threshold. But if you use a lower threshold of, say, $100,000 per life year saved, then that drug might be viewed as being not too expensive for that particular insurer. It ultimately depends on how much an insurer or how much society is willing to pay for new drugs or medical devices or different treatments, given their fixed resources and fixed budgets. In an article for Health Economics, economist Mark Pauly wrote that the conventional model for the use of cost-effectiveness analysis for health programs involves determining whether the cost per unit of effectiveness of the program is lower than some socially determined maximum acceptable cost per unit of effectiveness. So if a program is better by this criterion, the policy and location is that it should be implemented by full coverage of its costs by insurance, and if not, the program should not be implemented at all. He also wrote that the incremental cost effectiveness ratio is compared with that threshold value W for acceptable cost effectiveness stated in terms of a maximum value for dollars per quality adjusted life year that will be socially accepted or approved, and this can be interpreted as a measure of society's willingness to pay for quality adjusted life years. The cost effectiveness threshold may ultimately be determined by a budget constraint. And so, as noted in one study, the makers of health policy initially used cost effectiveness analysis for priority setting and their attempts to ensure that the greatest possible health benefits were achieved given the available budget. They also noted that cost effectiveness analysis and the cost effectiveness threshold could also be used as a bargaining tool, say in price negotiations with pharmaceutical companies. So in cost effectiveness analysis, you've already seen where quality adjusted life years are commonly used. Recall that the quality adjusted life year multiplies the time spent in a health state for a disease by the self-assessed utility score of that health state, which reflects the desirability of living in a particular health state by patients where a year in perfect health has a utility score of 1, while death is equal to 0. So we saw this earlier when we were looking at the production of health. We also saw how this was used in cost effectiveness analysis to inform prescription drug pricing in the US, even though that has been quite controversial. So, for instance, in the US, the Patient-Centered Outcomes Research Institute, which was established under the ACA, is not able to use a dollars per quality adjusted life year or similar measure that discounts the value of life because of an individual's ability as a threshold to establish what type of healthcare is cost effective or recommended. And this is just one of many controversies surrounding the use of cost effectiveness analysis in the healthcare sector. Another study noted that the optimal strategy identified by this cost effectiveness threshold is rarely the sole contributor to decision making, and other factors such as distributional and ethical concerns, feasibility, affordability, and political discourse may also contribute to an alternative choice of optimal strategy. Even so, they continue quantifying the trade-offs, and health benefits and resource use improves the accountability and transparency of such decision making. So the above framework is looking at the incremental cost effectiveness of an option for an entire population on average. But we should also consider how cost effectiveness analysis and the incremental cost effectiveness ratio can be used for heterogeneous populations. So a few studies have explored this whenever we have different populations with different health needs, and that might allow us to incorporate more health equity concerns into the traditional cost effectiveness analysis toolkit. But as Burnell notes, this does not necessarily address the ethical dilemmas. It does not recommend whether the intervention should be implemented, and it does not tell you whether a program is actually needed. It's just one tool among many for health policymakers when they're considering how to allocate scarce healthcare resources. And with that in mind, in this week's module, we'll consider the following exercise. Suppose the health department in a small country has been given a budget of $10 million to spend on new drugs. Its objective is to maximize health gains per dollar spent, and the department's analysts have developed a list of drugs that could be covered by the insurance program, together with estimates of their incremental cost and incremental benefits in terms of quality adjusted life years saved. So we'll go through an application and this week's module assignment, and I'll present a few of this application later in the course. Here ends the slide presentation for Chapter 9.